All right, so continuing with chapter 20. So first of all, I want to stress that this is not your toxicology or your pharmacology lecture that you're going to get in your programs. I'm more interested in you having general knowledge about the classes of drugs and how they work, not having you memorize a ton of drug names and knowing what they apply to. There are a few, and they're listed very clearly in the PowerPoint, and those are the ones I would expect you to know. But this lecture is more of a general, what do we want out of an antimicrobial drug, and can we really achieve that goal? Okay, so mechanisms of drug action just simply means how do they do what they do. So here are some of the different ways that these drugs act on cells. Inhibition of cell wall synthesis. So you probably remember me talking about peptidoglycan and penicillin. That would fit into that category. There are drugs that actually inhibit nucleic acid structure and function. So whether it's replication or transcription, acting on the ribosomes is going to result in protein synthesis or translation being disrupted. There are some that act like surfactants and go in there and just basically rip apart the cell membrane. And then this is specific to a class of drugs called sulfa drugs, which are commonly prescribed for urinary tract infections. So this is not going to be on the exam. Okay, I'm not going to give you this. Here I am. Look at me. Look at how dumb I am. I'm trying to pinch my computer screen. Okay, so I just want you to know that some of these, you're probably familiar and have taken some of these drugs. So, for example, erythromycin, clindamycin, tetracycline, streptomycin, those are probably familiar to you. Those are acting on the ribosomes of the bacteria. Cell wall biosynthesis, of course, we've talked about penicillin, cephalosporin, vancomycin, you may have heard of these others. Quinolones, you may have heard of that. That's acting on DNA replication. Polymyxins act on the cell membrane. Polymyxins tend to be drugs that go on your skin, so they're not taken internally. And then finally, sulfa drugs, and that's where we're talking about folic acid synthesis. Okay, so here's an example of ones that I do want you to know. So drugs that affect the bacterial cell wall, these are the ones that are preventing intact peptidoglycan from being put together. So we've talked about penicillin a bunch previously in the semester. The cephalosporins also fit into these categories. And really, these are about the most perfect antibiotics or antimicrobial drugs that could have been invented because they're acting on peptidoglycan, which is found only in bacteria and not in us. The other thing that made them so great is they worked in bactericidal concentrations. And so you could give them in really low concentrations, and because they were affecting just the bacteria, they would kill just the bacteria. Remember, most of these drugs we have to give in bacteriostatic concentrations, but this was one where, nope, we didn't have to. Unfortunately, we've developed resistant strains due to antibiotic overusage, and also a lot of people, myself included, have allergies. So I'm allergic to penicillin. One of the other drugs that fits into this category is called vancomycin, which is considered, kind of the slang name is the antibiotic of last resort. And it's used to treat those patients that have MRSA infections, which is methicillin-resistant Staphylococcus aureus, which is a superbug. Those types of infections, in their blood or inside the body. So vancomycin is one drug that you do not want to take unless you absolutely have to. So if your doctor is saying, oh, you have a sinus infection, let me write you a script for Vanco, you need to run screaming and find another doctor because nope, you don't use that unless you absolutely have to. So here's how these drugs work. They go in and they prevent peptidoglycan from being put together And so what ends up is the cell wall can't be formed. And so you just have a cell membrane, which is, you can basically pop holes in the cell and then the cell lyses. And so here are some electron micrographs of what happens when bacteria are treated with these types of drugs. They literally just disintegrate. Okay. When we talk about nucleic acid synthesis and affecting that, you can have drugs that inhibit DNA replication. And remember, the DNA replication is needed for cells to reproduce themselves. So you basically stop cells from reproducing. It also, you can stop transcription. So if you can inactivate RNA polymerase, then you're not going to produce messenger RNAs. And if you stop transcription, you automatically stop translation and no proteins are made. The drug that I want you to know in this category is ciprofloxacin. So routinely just called Cipro. It's a very commonly prescribed broad spectrum antibiotic, but it's acting at the level of the DNA. Okay, then we have these drugs, and yes, you should know these. So erythromycin, clindamycin, tetracycline, streptomycin. What these do is they go in and they somehow interact either with the messenger RNA or the ribosome. Okay, so this is kind of why I went over DNA and went through those different processes, because I wanted you to understand how these drugs work. So some of them go in, and let me see if I show that on the next slide. Yep, I do. Okay, so here we have a ribosome. Okay, and here's the messenger RNA. And remember, the ribosome sits on the messenger RNA, and then it reads it 3 base pairs or 1 codon at a time. Okay, so what chloramphenicol is doing is it's preventing the 2 amino acids from being joined together. Okay, let's see. I can't even pronounce that name, I'm sorry. But what it's doing is it's causing the large subunit and the small subunit of the ribosome to detach. So now you know how have an intact ribosome. Obviously, that drug name is not going to be on the exam because I can't pronounce it. Tetracyclines, what they do is basically, sit on the messenger RNA. So it's right here. And then the ribosome can't move to the next codon. It's basically stuck right there. Erythromycin does basically the same thing. It sits its big hiney down on the messenger RNA. The ribosome keeps bumping into it, and it can't read the messenger RNA. Okay, let me make this clear though. For the exam and for the quiz, you do not have to memorize these different, what they're doing. All I want you to know are that these are the drugs that block protein synthesis. Okay, that's all the further detail that I expect you to know. Okay, then we have drugs that attack the cell membrane. And these are what we call polymyxins. The best example of this is Neosporin. So these are, this is not something that you want to ingest. It's something that normally just goes on your skin, and you're trying to, put it over, say, what you think would be an infected cut, and try to reduce bacteria, in that way. And the reason you don't want to ingest these things is because, guess what? Of course, you have cell membranes, as well as the bacteria that you're trying to destroy, or, fungi that you're trying to destroy. The reason you can put it on your skin is because you have that outer layer that are basically, proteins and dead skin cells. So you're not killing anything, but you are potentially killing the bacteria or the fungi that's in there. But yeah, polymyxins only go on the skin. Okay, then I want to talk about sulfa drugs. Okay, so sulfa drugs are usually used to treat urinary tract infections. And what they do is they inhibit folic acid synthesis. Now, you probably see folic acid on your multivitamin if you happen to take a vitamin. Pregnant women need a higher level of it, so it tends to be higher in prenatal vitamins. However, this is what I want you to understand. You use folic acid completely differently from how bacteria use folic acid. So bacteria use it to make pretty much all of the building blocks that they need, all the nucleotides, so the A's, G's, C's, T's, and U's, and then also amino acids. Okay, you guys don't do that. But this is why it's important to block it or have a way to block it in bacteria, because if the bacteria can't make nucleotides and it can't make amino acids, you know, it's going to shut the cell down, and eventually the cell is going to die. Okay, once again, do not memorize this. I'm not going to put on a quiz question. What is dihydro? No, I'm not going to do that. All I want you to see, and this is a perfect example of bacterial resistance. Okay, so this was the pathway for bacteria to make amino acids, and then these refer to the A's, G's, C's, and T's, and U's, fancy names are purines and pyrimidines. So this is what sulfa drugs do. They block that pathway right at the beginning. So guess what? Can't go further, and they can't make these. Now, the bacteria has fought back, and through random genetic mutation was able to develop an enzyme that would break apart the sulfa drug. Okay, so now you've got a resistant strain. So now the brainiacs in the lab fight back. And if you are diagnosed of having one of these resistant strains, then what you do is you first treat the patient with trimethoprim, which breaks apart the enzyme that breaks down the sulfa drugs. Once you've done that, then you can treat with the sulfa drugs again. Okay, so it's a perfect example of how we develop a drug that, or I shouldn't say we, not me, okay, the smart people develop a drug that they think is really going to work well. And then it's only a matter of time until the bacteria develop a mutation that allows them to defeat that drug. And then we have to come up with another drug to try to, kind of defeat the bacteria again. So it's literally a back and forth. And, it's drug warfare. I mean, it's happening with resistant strains all the time. Okay, so, I'm going to keep going for a little bit. Okay, so there are about 260 different types of antimicrobial drugs classified into 20 drug families. Okay, don't memorize those numbers, I'm just telling you. But the largest number of those 260 drugs are for bacterial infections. And it's because we're constantly battling bacterial infections, and it's a little easier to develop drugs against bacteria because there are definite differences between bacteria, which are prokaryotes, and our cells, which are eukaryotes. So when we're talking about fighting infections against fungi, protozoans, and worms, our drug options are a lot fewer because their cells are so similar to our cells because we're all eukaryotic. And then, of course, antiviral drugs, that's a whole separate problem because the viruses are using our cells to make more copies of themselves. And so we basically have to destroy our own cells. So yeah, treating viruses is incredibly hard. The best thing you can do is, get vaccinated if a vaccine is available. So let me first talk about fungal infections. Okay, so fungal cells are eukaryotic. They look exactly like us pretty much. They have a nucleus, they have mitochondria, they have all of the stuff. So, obviously an antibiotic will not work on a fungal infection. Remember that yeast is fungi, and a yeast infection is a fungal infection. So a lot of your patients are going to think yeast are bacteria, and they are not. So an antibiotic against a yeast infection would be completely ineffective. So most fungal medications, antifungal medications, are topical, meaning that they're put on the skin. If there is an internal fungal infection, say if a person has fungal meningitis, which is incredibly dangerous and scary and hard to treat, those medications have to be monitored very closely because of the similarities in our cells. And what that means is that they are very toxic to our cells. So internal fungal infections are very hard to treat. Even a yeast infection, that's considered more topical. So, those are a little easier to treat. But yeah, it's simply because they are so closely related to our cells, and actually they have an extra advantage because on top of their cell membrane, they have a really thick, sturdy cell wall too. So it's actually much harder to get medications into fungal cells when we're taking those medications internally. So yeah, you'll notice if you're ever, prescribed one of these, the pharmacist is definitely gonna wanna talk to you, and they're gonna monitor you pretty closely. Okay, if you are infected with a worm, so even microscopic worms are still eukaryotic, and they're still pretty big in terms of the scope of looking at something under the microscope. They're certainly much bigger than bacteria. So most of the drugs are used to cause the worm to disintegrate. And then also, remember, in the case of tapeworms, if you don't get rid of the tapeworm head and get that to detach, you're not going to get rid of the tapeworm. It's just going to keep generating more segments. So you basically have to take drugs that make your intestines a very inhospitable environment. So it's not a picnic for the human either. You're going to feel pretty sick when you're taking these meds because you have to make your intestines basically really toxic. So that's what a lot of these drugs do. They're going to either attack the metabolism of the worm, or they're going to cause it to disintegrate and kill it that way. Okay, antivirals, we talked about this in the virus chapter. One of the worst things is that selective toxicity, almost impossible to achieve with a viral drug because the virus is inside your cells. So there are some viral drugs. The best thing you can do is prevent that virus from getting into the host cell in the first place. That would be achieved through vaccination and then having antibodies that basically act like sponges and suck up that virus before it reaches the cell. There are some medications, like AZT, that will act on reverse transcriptase and some of the, transcription and translation of specifically of viral molecules. And there are a few drugs that can prevent all of the parts of the virus from being put in together, but also, toxic to our cells because the virus is inside our cells. So yeah, antiviral drugs are hard to develop. Okay, so that's where I'm going to stop. And then we'll have a part 3 that'll finish up chapter 20, and we'll start here next time. Thank you.